Furosemide in pregnancy, risks, precautions, and dose. 1. Overview. Furosemide is a loop diuretic used to treat conditions like edema and hypertension. Its use in pregnancy is generally limited due to potential risks to both the mother and fetus. It is categorized as pregnancy category C by the FDA, meaning animal studies have shown adverse effects, but no well-controlled human studies exist. 2. Risks. Maternal risks, hypovolemia, electrolyte imbalances, e.g., hypokalemia, hyponatremia, and dehydration can occur. Fetal risks, potential for intrauterine growth restriction, IUGR, due to reduced placental perfusion. Ototoxicity has been reported in neonates exposed to high doses in utero. Risk of electrolyte imbalances in the fetus. 3. Precautions. Use only if the benefits outweigh the risks, particularly in cases of severe edema or heart failure unresponsive to safer alternatives. Monitor maternal blood pressure, renal function, and electrolytes closely. Assess fetal growth and amniotic fluid levels regularly. 4. Dose. The usual adult dose of furosemide for edema is 20 to 80 milligrams per day, but in pregnancy, the dose should be minimized to the lowest effective amount. The dose and frequency may need to be adjusted based on clinical response and maternal fetal monitoring. 5. Key points. Avoid routine use during pregnancy unless medically indicated. Consider alternative therapies for managing hypertension or mild edema in pregnancy, such as methyldopa or labetalol. In cases of life-threatening fluid overload, e.g. pulmonary edema, furosemide may be justified under close supervision. If you have a specific case in mind, I can help tailor recommendations. Furosemide use in pregnant rheumatic patients, risks, precautions, and guidelines. In pregnant rheumatic patients, the use of furosemide may be considered in select situations, such as managing complications like heart failure, renal involvement, or severe fluid overload, e.g. pulmonary edema, associated with diseases like systemic lupus erythematosus, SLE, systemic sclerosis, or antiphospholipid syndrome, APS. However, its use requires cautious consideration due to potential maternal and fetal risks. Indications in rheumatic patients. 1. Heart failure, common in patients with SLE or APS due to cardiomyopathy, valvular lesions, or pulmonary hypertension. 2. Nephrotic syndrome or renal involvement. Furosemide may help manage fluid retention secondary to lupus nephritis. 3. Severe edema, when conservative management fails. Risks in pregnant rheumatic patients, maternal risks, exacerbation of renal dysfunction, particularly in patients with pre-existing lupus nephritis or systemic sclerosis. Increased risk of electrolyte imbalances. Fetal risks, intrauterine growth restriction, IUGR, due to reduced uteroplacental perfusion. Risk of oligohydramnios from excessive diuresis. Precautions. 1. Multidisciplinary care. Collaboration between rheumatologists, obstetricians, and nephrologists is essential. 2. Monitor maternal electrolytes, renal function and blood pressure, fetal growth, amniotic fluid volume, and Doppler studies to assess placental blood flow. 3. Use the lowest effective dose. Start with 20 to 40 milligrams per day, adjusting based on clinical response. 4. Combine with disease-specific management. Address the underlying rheumatic disease with appropriate immunosuppressive or anticoagulant therapy as needed. 5. Avoid long-term use to minimize risks to fetal development. Alternatives. Use safer antihypertensive agents like methyldopa or labetalol for blood pressure control. Manage mild edema with conservative measures, such as leg elevation and compression stockings. Summary. Furosemide should only be used in pregnant rheumatic patients when clinically necessary, such as in cases of severe heart failure, pulmonary edema, or nephrotic syndrome, and always under strict monitoring. Balancing maternal benefits against fetal risks is critical, with a preference for alternatives when possible.